Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm Amanda Mixon, and today we are continuing our GCA Fireside Chat series with an episode that takes us straight into the data. Today's conversation unpacks one of the most talked about trials in recent vasculitis research. The SELECT-GCA study has brought new attention to targeted therapy in giant cell arteritis, and today we're going to break it down, the study design, patient population, primary and secondary outcomes, and what actually this means for clinical practice. Today, I am joined by two absolutely fantastic guests, Naomi Amadala, nurse practitioner, and Dr. Peter Merkel, who are obviously our resident vasculitis experts in GCA. And so, Naomi, our listeners are probably pretty familiar with you, but Dr. Merkel, could you give us a brief introduction?
I work with Naomi Amadala. I am, and that's my claim to fame as a collaborating physician. I am a professor of medicine epidemiology at the University of Pennsylvania, where I am chief of rheumatology, and I have been studying vasculitis, all forms, and taking care of patients with vasculitis for 30 years. I run an international research network, and I do clinical trials, genomics, epidemiology research, et cetera, all things in vasculitis. And I was an important part of this trial. I was part of, I worked with the company to help design the trial quite a number of years ago. I've been involved in its implementation and then interpretation. And I was the senior author on the New England Journal paper that reported out on the results that subsequently led to approval by the FDA and many other countries for its use in giant cell arteritis.
Well, again, thank you so much. What an honor to have you both here. Whether you've read the study in full or are hearing about it for the first time, this episode is an opportunity to explore how the data might shape the way we approach treatment for giant cell arteritis now and also in the future. So I'm going to get right down to it and ask some questions of both of you. I will start with you, Dr. Merkel, since you obviously are so intricately involved with this study. Can you talk about the primary objective of SELECT-GCA study and why was this research needed?
So, giant cell, although glucocorticoids work, prednisone and the company work very well. They're incredibly effective for giant cell arteritis. I think, as we all know, as rheumatologists, that, as I like to say, except for the cataracts, the glaucoma, and the insomnia, and the psychosis, and the osteoporosis, and the weight gain, and the diabetes, and the hypertension, and the heart failure, they're great drugs. So they're the best drugs we have, and they're the worst drugs we have. And we're looking for ways to be glucocorticoid sparing for our patients. If there's a population that's the most vulnerable, it's patients with giant cell arteritis in their 60s, but especially 70s and 80s. And so the toxicity opportunity is very high, unfortunately, for glucocorticoids. So we're looking for drugs that can help spare. Tocilizumab, we know, is available as one option, thanks to some trial work as well. There's some other trials that are happening now, which are interesting, including one reported out negatively last week or two ago. But this was a study of Upadacitinib, which is, I don't usually, so Upadacitinib is a JAK inhibitor, and it's a slightly selective JAK inhibitor. And the reason it was done is because there's evidence from basic science and translational work that the JAK-STAT pathway may be important in giant cell arteritis, as it is in many of our systemic rheumatic diseases. And the idea was, let's try a JAK inhibitor in this disease. It should do all the right things from an immunologic standpoint. What was interesting about this is, I remember when we first talked about this with the company and designing it, is there was no actual preliminary data. The idea was to go straight into a phase 3 labeling study, which has really not been done before in giant cell arteritis and almost never done. The reason for that is there was a lot of data for this drug in rheumatoid arthritis, psoriasis, and other things, inflammatory bowel disease. And so there was a comfort level with the drug. And the feeling was there was a high confidence that it could work. And if you're going to do a small you end up doing the big study anyway. So they took a chance and did a big study, an over 400-person study. I don't know if you want me to describe the thing. So the rationale was, this is a drug that should work quickly and effectively to reduce the inflammation in giant cell arteritis, to allow patients to come off glucocorticoids more quickly, but also stay off them without relapse.
Naomi, do you have anything to add in terms of the why?
I do have actually a question to one of Dr. Merkel's comments. So the study duration was 52 weeks. Is that
That's correct. Yeah.
And so, your point of staying off glucocorticoids, which I think is really important for patients, you could say that study only lasted 1 year. So is there any interest, or what do you think about kind of what the landscape looks like after 52 weeks and patients being able to stay off?
That's a great question. It wasn't planned for the audience. So we actually have data from the SELECT-GCA on year 2. So the year 2, which was it was a blinded extension study where people were either stayed on it or were put on placebo. They were re-randomized. So it's kind of complicated. So if you were on placebo, you stayed on placebo. If you were on other ones, you could be randomized to either continue the drug or go on placebo. So it got kind of complicated, and I've seen these data, and they're very interesting, and we have put them in for national meetings. Can't really speak to that until they've been accepted and say. So that's exactly right. So it was planned from the beginning to try to answer your question, your implied question, which is, what happens when you stop the drug? Are we just moving this curve so that the same number of people are going to relapse? Have we waited long enough so that maybe fewer people will? Do they rebound worse? This is a good question, because this is the question we have with tocilizumab. It's the question we have with methotrexate. With tocilizumab, we know, you know what? You stop the drug, a lot of people relapse. And you start it again, they do better. So we're not necessarily changing the underlying biology, but we're changing the time course. But are you changing it so that they can recover quickly? They don't have to be on glucocorticoids much. Maybe they go in a bit. The other thing is, traditionally, people have been on glucocorticoids for a very long time. Some people would argue for years. Some people say 2 years. Many of us have tried to go much shorter anyway and see what happens, and then put them back on if they have to. This design was to get people off by week 26 if they were on drugs. So it's 6 months, while the placebo group was on it for 52 weeks. The other thing I would add is that we know from trial data, and patients who have been, once a patient's diagnosed and they're under care, their chance of getting monocular blindness or stroke or something bad is actually very, very low. Not impossible. And it's low because the patient knows they have the disease and the provider knows they have the disease. And so they are the early warning system, the patient is, and they're going to report they have a headache, they have fatigue, they have aches and pains, the visual changes right away. And so we're going to hop on it. So patients basically almost never in these trials get into big trouble. They get into trouble, but not in big trouble during the trial from reactivation of disease. It happens and then you treat it. The reason I say that is we may have more opportunity than we think in general to taper glucocorticoids and watch patients carefully. Because, as I often say, the hardest thing to do in medicine is to not treat. The second hardest thing is to reduce therapy. Because this disease makes you nervous. It makes you nervous, this disease.
Of course.
And the patients call and say, well, I sort of have a headache. So we're trying to empower patients and providers to get off glucocorticoids. But I would add something else. Glucocorticoids, prednisone, work really well. And sometimes a low dose is what you need. So it's not all or nothing.
Well, so you mentioned, obviously the goal is getting these people off of steroids, maintaining, remission, achieving remission. I guess the first question that I have is, who actually was in the study? So what was the key inclusion and exclusion criteria as we looked at this trial?
So patients had to have active giant cell arteritis, either new onset or recurrent disease. And they could have either. And then they were and they were put on glucocorticoids. There was a set protocol dose. That's very important in trials of giant-cell arteritis. If you let the providers and the patients do a new on glucocorticoids, you have too much what we call noise in trials. So you have a set protocol. So they come in at a certain point, and they're different weeks that they've been on. And so they have active disease that was clearly active giant-cell arteritis. They had to have met diagnostic criteria that we put together, and they had the disease. Then, if I might well go on with the rest of the design, if that's okay. So once they were enrolled with active disease recently, and they may not feel active that day, but they had it within a few weeks, and they met inclusion criteria. So there are also a lot of exclusion criteria. So you couldn't have had cancer within 5 years. You couldn't have had infections. It's usual criteria. You didn't want to have a blood clot. You didn't have other things that would be worrisome or active things. Then they were randomized to one of 3 groups. So it's a complicated design. They either were on placebo, so they got a 52-week slow glucocorticoid taper, which was still considered standard of care by the FDA, more or less. Or they got upadacitinib, but I'm going to just call it UPA during this. So they got UPA 7.5 milligrams daily, or they got UPA 15 milligrams daily. Now, these are doses we use in rheumatoid arthritis. Now, people go into higher doses, sometimes of 30, especially for IBD and other things. But we tested these 2 doses. It was the right thing at the time versus placebo. And the people who got the active drug had a 26-week or 6-month taper of glucocorticoids. And they had the same taper. And in some ways complicated, in some ways simple, because the outcome of interest, the primary outcome was relapse. It was really remission, which is the inverse. Did the patient stay in remission? Did they stay in remission off glucocorticoids at 52 weeks, having been off for a while? And did they do it with or without a low CRP? The CRP, C-reactive protein, it gets messy with these newer drugs because many of them actually influence the CRP, even if they're not treating the disease. And so we want to show it with and without that. We had a series of secondary outcomes. How did people feel? Was there fatigue? Glucocorticoid dose, a bunch of them, including patient-reported outcomes. There were, I think, about 12 of them. And we put them in order. We had a hierarchy, which said, if you hit the first one, then you can analyze the second one. If you hit those 2, you can analyze the third. But once you don't see a difference between active drug and placebo, you stop analyzing the secondary outcomes. So it's a little more rigorous statistical approach to secondary outcomes. Maybe that's a little bit more detailed than you want, but it's important because it's not just about a patient's remission or not. We want them to feel better. We want them to function better.
Right.
We want them not to get sick.
Well, it's so important, especially because this is a good, option for people that don't want to have IVs or injections. People like taking daily pills. So it's nice to know, how this whole trial was put together. I think let's get to the crux of it, which I think most of our listeners are going to want to know. Can you talk to me about the key findings of the study?
Sure. It works. So this was a positive trial, which is nice because you like to see, we're trying to get new options for patients. It didn't work in all the groups. So interestingly, the UPA 15 group versus placebo were clinically and statistically significant, more likely to get into durable remission. They also hit 9 out of the 12 secondary outcomes superiorly to placebo. The UPA 7.5 group did not. It actually was numerically higher and it was close. It was very close p-value, but it didn't hit it. And so we were pretty strict and said, okay, we're not going to go with that dose. But there was a hint, I can say this, there's a hint of a dose response here because it was better, but not as good. Because the outcome was clear, it was clearly better than placebo. The Food and Drug Administration, the EMA, and others have approved the use of this drug in giant cell arteritis. So it's now available. That's very important. If drugs don't get approved, then insurance companies are going to pay for it, et cetera. So it's endorsed. and it's improved at the 15 milligram dosing per day. And you're right, it's a pill, it's once a day.
Well, I was just going to talk about maybe some of the strengths or limitations of the study, because I do think it's important that we, touch on those things.
I mean, the strengths of the study were that it was double-blind placebo-controlled trial, our strongest approach to studying disease. Not the only way. And for rare diseases, we tend to do other designs. But this was the strongest approach to studying a drug. Another strength was that it was large. This was a large study. So we were powered properly to be able to see an important difference. The difference we picked was clinically important. You could have a zillion patient study and show a small difference, but if it's not clinically important, it's not helping our patients. So I think, and we measured, everything. So it was very carefully done at centers that people who knew what they were doing. It was well monitored. The other strength, in addition to the findings of efficacy, was that the safety was good. We know about this class of drugs, but we didn't know about it in a concentrated group of patients who were older. And we didn't know about it in a concentrated group of patients who were on high-dose glucocorticoids. So we're pretty pleased with it. A few more cases of zoster than the placebo, we'd expect that. But interestingly, the other three areas that we could most worry about for JAK inhibitor, we didn't see a difference in cardiac events, so-called MACE events, major cardiac events. We didn't see a difference in other infections besides the zoster risk we know about, and we didn't see a difference in clotting. And so that was good, because if you saw a difference, that would be concerning. Caveat is, and again, I don't work for the company, I work for our patients, is that it's only a couple hundred patients. So if there were relatively rare events, you might not see it. But it's consistent with what we know about the drug. So there's been concern about cardiovascular events with JAK inhibitors, but that actually is based on other JAK inhibitors, and it's a little controversial. There's concern about clotting, but again, that's tocilizumab or baricitinib, and not necessarily with this drug. But it was good. So we were pleased with the safety outcomes. And of course, it's a selected study of patients who have who were in a trial.
So the drug works and it's safe. And again, to your point, we know about this medication. We all are very familiar with this therapy. So it's nice to know that we have another disease that we can use it in. Naomi, I'm going to put this one to you. So, obviously you know the data really well as well. So how do you see all of this in terms of how do you interpret this? And then how does this change your practice, or does it change your practice? Because obviously we all also, I think, are pretty comfortable using toci for GCA. And how does this maybe shift or change, or maybe it doesn't?
I think it's exciting that we have a third option now for giant cell arteritis. When I started doing this 15 plus years ago, really it was only methotrexate, and then tocilizumab came on, and now we also have upadacitinib, which is good. I was thinking about it, and actually going back to your question that you just asked about limitations of the study, and one thing I believe is that if you have flared when you were on tocilizumab, that it was an exclusion criteria.
No?
It was not.
No, you could have seen toci before, but we had very few patients that actually had that. So we can't really give a lot of opinion about it. But it's a very good point. I think you can go on. I think you're also saying this would be an option for patients who had trouble with toci.
Yes, right. And then I guess to that point too, if we don't have a lot of patients who are in the trial who were previously on toci, do we know kind of how efficacious UPA is going to be for those patients, the toci naive patients, I guess?
So I think that's an important and sophisticated point, which is if you take patients who have had so-called resistant disease, are they less likely to respond to a new therapy or any therapy? And we have a lot of patients who had relapsing disease in all of these trials. We actually haven't seen a big difference in that per se, but it can be. So you have to keep that in mind. But I think that we don't have the luxury of doing all of these different permutations. But I do think that we know this even from prednisone, the patients who then relapse, they usually get back into remission rather quickly. So it is predictive of people who are more likely to relapse later. So if you select for people who had relapsed, you might be predicting a more relapsing group of patients. So that makes them, maybe they'd be harder to treat. The other thing that was interesting about the trial is that it was done partially during the pandemic. So many of our trials recently that are reporting out were done. So that's just interesting. It changes things a little bit.
And the infection rates were similar, or I think higher in the placebo group.
They were, if anything,
compared-
higher, but they're not statistically different. But infections weren't that. Now, maybe everybody was at home with COVID for a while, or afraid of COVID. And so it changed. We noticed that in other trials, actually. So it's very hard to compare this trial to JAK-STAT because they were done at a different time, a different population. And so it's hard to do that. So it is interesting, but it adds another option. It's not for everybody. And I think it's a happy problem to have more than one drug.
No, I know this wasn't studied in the trial, but the 15 milligrams is what is FDA approved for GCA. If you saw that UPA was partially controlling the disease, do you see any room or any future in increasing the dose? Do you think there's a ceiling effect with the drug?
Well, officially you can't say that because that's not approved dose. How do providers have the option to use approved medications for off-label use? They do. Will you get approval for that by providers? I don't think it's unreasonable in select cases, so to speak, to consider increasing the dose. We certainly do that with some of our other drugs. So certainly many people will try adalimumab every week instead of every other week for some people. Patients certainly are creative in their self-dosing schedules. So I think it is something to consider, but there may be more toxicity with higher dose. I think it depends on the patient in front of you. Have they already been on another drug? Are they running out? Is their risk of glucocorticoids very high or just average? So you have to individualize it. But I think it's a good point. We're not quite there. We just started using the drug. So, but it is an interesting point. And it's always been a point in the treatment of giant cell arteritis, which is what we're talking about. So methotrexate, I think, has been shown to be efficacious. It's a little bit controversial, and there's some new studies that are coming out that may help us. But we did a meta-analysis. We took all the individual patient data. It was actually better than the meta-analysis, put it together. Efficacy, it's probably not as strong as these two drugs we're talking about here, toci and UPA. But many of those studies, the maximum dose was 15 milligrams weekly. And back then, before both of you were practicing, that was considered moderately high dose. We now, of course, go to 20 and 25. So many of us who, as you know, Naomi, because we do it together, when we give someone methotrexate for this disease, we're going to go up higher. So we're going beyond the trial. But you have to remember that you're going outside the trial parameters. And it's always good to step back and say, is this a good idea? Am I comfortable doing that?
Definitely. Well, any final thank you so much, obviously, for talking all about this. I definitely have a very clear understanding of this trial now. Any final thoughts when we talk about the trial before we wrap up?
I want to make sure that I'm not just selling this study per se. This was a very well done study, and we got very clear results. And this drug is effective and should be used, but it is a conversation with patients. Do you want to take a pill every day? Do you want to take toci with a shot? Are you unmedicated? So you'd have to get toci by IV, at least in the United States, that's a problem. Do you want to take nothing? Do you have osteoporosis? Do you not? What is your risk of glucocorticoid toxicity? It ranges from yes to yes, yes, yes. And do you have history of diverticulitis? Do you have a history of coronary artery disease where you may be less likely to start? So you have to, I think it's important for us as providers to know the toxicity of the class of drugs and that weigh that when you describe to the patients. I saw a new patient today with giant cell arteritis, new to me and new onset, and we discussed these options. And it is not a quick conversation. It is a long conversation about these options. And I think that's what we should do. So I would encourage people to look at the report and go back and look at the study design, because I think it's helpful not only for the science and reading the next paper, but it's helpful for how you frame your conversation with patients, because the trial, what we did is what we do in practice. I don't know if that makes sense, but look at the JAK design, look at the SELECT design, and how do we apply it for patients? And the other thing I'd say is give it time to work, and if it's not working, think of something else. We can treat this disease. We should be able to treat our patients well with this disease. But we do, and it doesn't work for everybody. We're going to need other drugs. I'm running another trial for another drug. So there are other options.
Yeah, which is so amazing that we do have other options. Naomi, any final thoughts?
No, I thank you, Amanda, for inviting us onto this podcast. I do appreciate it. And thank you, Dr. Merkel, for going over the SELECT trial in such detail. It was really good to hear. It's very clear.
Can I just tell you, having more drugs for our patients is a happy problem.
I couldn't agree more. Both Naomi and I have been practicing for about the same amount of time. And so we've had the kind of the luxury, I guess I would say, of seeing all these drugs get approved, but also the perspective of starting at a time where we didn't have all these drugs, right? So it gives an additional insight, I think, when we saw the people in the wheelchairs with the terrible deformities and the blindness and the terrible manifestations. And so it is so remarkable to see these new therapies come out every single year and kind of know how much we've evolved certainly in my 18 years, and Naomi, I think 16, 17?
Seeing it.
Yeah. So it's just pretty amazing. And I would guess Dr. Merkel is a little bit longer than that.
So I can 30 years, but I can tell you what you all agree. We can all agree on. It is great to be a rheumatologist and to be able to help our patients. It is a different field than it was when I started. And it's continuing to get better. Why would you not want to be a rheumatologist? We most interesting cases, we're the smartest people, we're the best looking. It's a great thing to be.
I can only imagine what it would be like to work with you every day. Well, again, thank you so much. So, well, that concludes our deep dive into the SELECT-GCA study. It's an important piece of evidence that's shaping the way we obviously treat giant cell arteritis. Again, thank you so much to both of you. Please join us for the next episode of the GCA Fireside Chat series, where we'll discuss the landscape of JAK inhibitors, how this fits into the broader treatment conversation, and what it means. If you're enjoying this series, don't forget you can stay connected to all things RhAPP by joining us on social media. We are on X and Instagram at Rheumatology APP, and Dr. Merkel loves his chapstick that he is showing us right now. And if you come to our conference in September in Denver, I promise you we'll have some chapstick for all of you. So with that, thank you so much for listening. We'll see you next time.